So good morning, everybody. Thank you for joining us this morning. My name is Sue Verrilli, and I'm the Regional Education Coordinator at the Northeastern Ontario Stroke Network. We're happy to bring you this session this morning on mirror therapy and its applications. I'm just going to remind you of a few things. Please make sure your microphone is muted. If you could put your cameras on, especially during the practice part of this session, that would be very helpful. Also have your mirrors at the ready because we're going to utilize them a little later on in the talk. We're recording this session, as I said, and archiving it on our Northeastern Ontario Stroke Network YouTube channel. Please type your name in the chat or rename yourself on the screen for my attendance records so I know who's attended and we can send out certificates of attendance. We will have a question and answer period at the end, so you'll be able to unmute and ask your questions, or you can type them in the chat and I'll relay them to Ven. At this time, I'd like to welcome our speaker, Ven Rajendran. Ven's a physiotherapist at Health Sciences North on the acute stroke unit. He's completed a graduate certificate in the stroke rehabilitation program from the University of Alberta and has a strong interest in stroke research. Ven did a mirror therapy session for us in 2020 and is now back to teach some hands-on training for using the mirror boxes. So welcome, Ven. Please go ahead.
Thank you so much, Sue, for the nice introduction. So I'm Ven, physiotherapist, as introduced by Sue. I work in a acute stroke unit primarily. Today, we are going to talk about mirror therapy and its application. It's a very simple and easy technique, which I don't think so we need 1.5 hours to practice. So I also brought Jim, who is one of the stroke survivor who used mirror therapy, who has a best experience, who is here to share his experience as well. So mirror therapy. So do you want to actually do that survey before we start the session? That would be great. Thank you.
Can you see it?
I don't see myself.
I'll try and relaunch it. Can people tell me if you can see it?
We can't see anything except for the main page that says mirror therapy.
All right, so it doesn't seem to be working. I'll try another one, but I don't know if it's actually.
Yeah, I can see Sue now.
Okay, thanks. Give it a few more seconds. Okay, that's most people, so I'll end it and I'll share the results. Can you see them?
Wonderful. I can see there are 9% of people are working in acute care and mostly from home and community care and rehab setup. 9% from outpatient clinic as well. Okay, and PT 11%, OT 54%, rehab assistant 29%. Thanks to all the rehab assistant, because this is one of the easiest technique you can do along with your OT and or PT. So in today's topic, actually, mirror therapy, although it can be applied for both upper and lower extremity, we don't have a mirror that suits the lower extremity need. So we are limiting this mirror therapy practical session to upper extremity alone. So the learning objectives are, so you will understand how the mirror therapy works and what are the factors that influence mirror therapy, and what are the different evaluation outcomes we can use to evaluate the outcome, effects of mirror therapy. And also you can develop some home exercise program using mirror therapy for stroke patients. If you attended my mirror therapy session in the past, you don't need to actually spend time watching this video. But if you're new, then actually we can spare a few minutes to watch how this mirror therapy has evolved and who is the author of this mirror therapy. The mirror therapy actually is invented by Dr. Ramachandran, who is one of the neuropsychiatrists, also a scientist in States. He actually primarily invented this technique for one of his amputee patient who experienced phantom pain, so which saved actually millions of dollars for pain medications. So I will play that video for a few minutes, then we will go through the session. Oh, it's asking me membership. I see. Okay, so actually I'm unable to actually share that link. It's asking me membership.
You want me to try?
Yeah, sure. Okay. Yeah. How about I share the web link to you?
Mm-hmm.
Okay. I'm unable to copy. How to copy this?
I think I have it here.
You have it there?
Yeah.
So it's a 3 clues to understand your brain. That's what I'm looking for.
Okay, I'm just going to share my screen, Van.
Sure.
And you can just let me know if this looks correct.
Okay, so I think I marked the wrong link. If you can, you see on the right hand side on the top 3 clues to understand your brain. If you can please click that, that would be great. Yeah. So we can watch from 9 minutes.
Okay. You want me to go to 9 minutes?
Yeah, please.
Problem when he sees it in person, he says it's an imposter. Okay. Now, how is all this complex circuitry set up in the brain? Is it nature, genes, or is it nurture? And we approach this problem by considering another curious syndrome called phantom limb. And you all know what a phantom limb is. When an arm is amputated or a leg is amputated for gangrene, or you lose it in war, for example, in the Iraq War, it's now a serious problem. You continue to vividly feel the presence of that missing arm, and that's called a phantom arm or a phantom leg. In fact, you can get a phantom with almost any part of the body. Believe it or not, even with internal viscera. I've had patients with the uterus removed, hysterectomy, who have a phantom uterus, including phantom menstrual cramps at the appropriate time of the month. And in fact, one student asked me the other day, do they get phantom PMS? A subject ripe for scientific inquiry, but we haven't pursued that. Okay, now the next question is, what can you learn about phantom limbs by doing experiments? One of the things we found was about half the patients with phantom limbs claim that they can move the phantom. It'll pat his brother on the shoulder, it'll answer the phone when it rings, it'll wave goodbye. These are very compelling, vivid sensations. Patient's not delusional, he knows that the arm is not there, but nevertheless it's a compelling sensory experience for the patient. But however, about half the patients, this doesn't happen. The phantom limb, they'll say, doctor, the phantom limb is paralyzed. It's fixed in a clenched spasm and is excruciatingly painful. If only I could move it, maybe the pain will be relieved. Now, why would a phantom limb be paralyzed? It sounds like an oxymoron. When we looked at the case sheets, what we found was these people with the paralyzed phantom limbs, the original arm was paralyzed because of a peripheral nerve injury. The actual nerve supplying the arm was severed, was cut by, say, a motorcycle accident. So the patient had an actual arm, which is painful, in a sling for a few months or a year, and then in a misguided attempt to get rid of the pain in the arm, the surgeon amputates the arm, and then you get a phantom arm with the same pains, right? And this is a serious clinical problem. Patients become depressed, some of them are driven to suicide. Okay? So how do you treat this syndrome? Now, why do you get a paralyzed phantom limb? When I looked at the case sheet, I found that they had an actual arm, and the nerve supplying the arm had been cut, and the actual arm had been paralyzed and lying in a sling for several months before the amputation, and this pain then gets carried over into the phantom itself. Why does this happen? When the arm was intact but paralyzed, the brain sends commands to the arm, the front of the brain, saying move. But it's getting visual feedback saying no. Move, no, move, no, move, no. And this gets wired into the circuitry of the brain, and we call this learned paralysis. Okay, the brain learns, because of this Hebbian associative link, that the mere command to move the arm creates a sensation of a paralyzed arm. And then when you amputate the arm, this learned paralysis carries over into your body image and into your phantom. Okay? Now, how do you help these patients? How do you unlearn the learned paralysis so you can relieve him of this excruciating clenching spasm of the phantom arm? Well, we said, what if you now send the command to the phantom, but give him visual feedback that it's obeying his command, right? Maybe you can relieve the phantom pain, the phantom cramp. How do you do that? Well, virtual reality, but that costs millions of dollars. So I hit on a way of doing this for $3, but don't tell my funding agencies. Okay? What you do is you create what I call a mirror box. You have a cardboard box with a mirror in the middle, and then you put the phantom. So my first patient, Derek, came in. He had his arm amputated 10 years ago. He had a brachial avulsion, so the nerves were cut, and the arm was paralyzed, lying in a sling for a year, and then the arm was amputated. He had a phantom arm, excruciatingly painful, and he couldn't move it. It was a paralyzed phantom limb. So he came there, and I gave him a mirror like that in a box, okay, which I call a mirror box, right? And the patient puts his phantom left arm, which is clenched and in spasm on the left side of the mirror, and the normal hand on the right side of the mirror, and makes the same posture, the clenched posture, and looks inside the mirror. And what does he experience? He looks at the phantom being resurrected, because he's looking at the reflection of the normal arm in the mirror, and it looks like this phantom has been resurrected. Now I said, now look, wiggle your phantom, your real fingers, or move your real fingers while looking in the mirror. He's going to get the visual impression that the phantom is moving, right? That's obvious. But the astonishing thing is the patient then says, oh my God, my phantom is moving again, and the pain, the clenching spasm is relieved. I remember my first patient who came in, my first patient came in and he looked in the mirror and I said, look at your reflection of your phantom. He said, and he started giggling, he says, I can see my phantom. But he's not stupid. He knows it's not real. He knows it's a mirror reflection, but it's a vivid sensory experience. Now I said, move your normal hand and phantom. He said, oh, I can't move my phantom. You know that. It's painful. I said, move your normal hand. And he says, oh my God, my phantom is moving again. I don't believe this. And my pain is being relieved. Okay? And then I said, close your eyes. He closed his eyes and move your normal hand. Oh, nothing. It's clenched again. Okay, open your eyes. Oh my God, it's moving again. So he's like a kid in a candy store. So I said, okay, this proves my theory about learned paralysis and the critical role of visual input. But I'm not going to get a Nobel Prize for getting somebody to move his phantom limb. It's a completely useless ability if you think about it. But then I started realizing maybe other kinds of paralysis that you see in neurology, like stroke, focal dystonias, there may be a learned component to this which you can overcome with the simple device of using a mirror. So I said, look, Derek, well, first of all, the guy can't just go around carrying a mirror to alleviate his pain. I said, look, Derek, take it home and practice with it for a week or two. Maybe after repeated practice, you can dispense with the mirror, unlearn the paralysis, and start moving your paralyzed arm, and then relieve yourself of pain. So he said, okay, and he took it home. I said, look, it's after all $2, take it home. So he took it home, and after 2 weeks, he phones me, and he said, doctor, you're not going to believe this. I said, what? He said, it's gone. I said, what's gone? I thought maybe the mirror box was gone. He said, no, you know, this phantom I've had for the last 10 years, it's disappeared. And I said, I got worried. I said, my God, I've changed this guy's body image. What about human subjects, ethics, and all of that? And I said, Derek, does this bother you? He said, no. Last 3 days, I've not had a phantom arm, and therefore no phantom elbow pain, no clenching, no phantom forearm pain. All those pains are gone away. But the problem is I still have my phantom fingers dangling from the shoulder, and your box doesn't reach. So can you change the design and put it on my forehead so I can, do this and eliminate my phantom fingers? He thought I was some kind of magician. Why does this happen? It's because the brain is faced with tremendous sensory conflict. It's getting messages from vision saying the phantom is back. On the other hand, there's no proprioception, muscle signals saying that there is no arm, right? And your motor command saying there is an arm. And because of this conflict, the brain says, to hell with it, there is no phantom. There is no arm, right? It goes into a sort of denial. It gates the signals. And when the arm disappears, the bonus is the pain disappears, because you can't have disembodied pain floating out there in space. So that's the bonus. Now, this technique has been tried on dozens of patients by other groups in Helsinki, so it may prove to be valuable as a treatment for phantom pain. And indeed, people have tried it for stroke rehabilitation. Stroke you normally think of as damage to the fibers, nothing you can do about it, but it turns out one component of stroke paralysis.
Can you share your screen, Ben?
Sure. Thank you, Sue.
Mhm.
Okay, from this video, what we
That's
understand
not
is,
your presentation, it's your other screen.
sorry?
You're not sharing your presentation, you're sharing your other screen.
Oh, sorry.
You stop sharing and start again.
That's all right. Go to Zoom. It's there. Can you see Sue now?
Yeah, just put it in
Presentation mode.
slideshow. Yeah. Mhm. There you go. Good.
Okay, wonderful. Actually, thanks for actually watching this video along with us. So in this video, we have to understand actually few concepts. The reason why I posted is because from this video, we need to understand few concepts, how the mirror was evolved for treating actually phantom pain, how this has been used in stroke rehabilitation. The main take home message is actually the vivid sensation. In order to create vivid sensation, we have to actually find out what are the best criteria can be used to create vivid sensation. So why mirror therapy? I will put all the points together because it's a very, very popular in treating hemiparesis. It's very easy to administer. As he mentioned, actually, it's not very expensive. It may cost actually $50-$60. Thanks to Sue for making mirror by herself along with her team and distributing to the Northern PTOT team. And also the Canadian stroke best practice guidelines recommend mirror therapy, and also Cochrane systematic review highly recommend mirror therapy as an adjuvant therapy. So you don't need to actually compromise any regular rehabilitation intervention, but you can supplement this along with your regular treatment protocol. And it's a level 1A evidence, which is one of the highest level of evidence. And mostly it can be self-administered by stroke patients with intact cognition. The beauty is actually you just need to educate the patient once or twice until they familiarize this technique. Then they can actually carry over this protocol. So you can actually focus on more manual techniques than the mirror therapy. But the problem is, when anything is easy, the people actually don't use it. The concept of this webinar is to re-emphasize the use of actually mirror therapy so that everyone will use it or maximize their usage to improve the stroke recovery. So other thing is actually, I just want to mention that our brain, has 20% of mirror neuron. For example, if I yawn, if Sue sees me yawning, so she will automatically yawn, right? So that's how our mirror neuron works. So even actually, if you watch any videos, which, if you see any sympathetic scenes, if somebody is crying, they may not be your relative. They're not related. You may still actually, exhibit tears, or you may be, so that's how our brain is very sensitive to visual impulses. So there are a few factors we need to consider when you're selecting mirror therapy for success. So one is patient selection. So you have to select the patient which is appropriate for mirror therapy. You cannot actually put mirror therapy for all patients. So you may say that your mirror therapy is not working. So that's the reason you have to choose the patient who would benefit from mirror therapy. The second thing is patient position. So you have to make sure the patients are comfortable in sitting or standing, because they have to create that vivid sensation. If they are not comfortable, their attention may focus on different things. They won't actually pay attention to the mirror, so they won't be able to create any vivid sensation. And also it depends on their sitting trunk control as well. And the next factor is mirror size. So mirror size is very, very important, because the whole limb has to be covered or has to be seen in the mirror. If you feel like, the mirror is whatever is available in the market, so it's very, very small, it covers part of the limb. So when you actually see the mirror, they may be able to see the hand, or they may be able to see the elbow. They may not be able to see the full arm. So when you want to create that vivid sensation, you have to make sure the full limb is visible so that the brain sees or take that visual input, and it create actually, a movement on the unaffected hand, on the affected hand. So the next is actually clinical environment. So when we look into the clinical environment, Jim is going to explain how later on. So how it's the environment is very important to maximize your results. So it has to be very, very quiet, and it has to be distraction free. And the position of the mirror. So of course you need to actually position the mirror in such a way that you can see the whole limb, and you can actually do movement, different type of anatomical movement when you're actually seeing the mirror. So that's how you need to position the mirror. There is no actually right or wrong rule in this case. As long as your patient is able to see the mirror, that's good enough. So other question we may have is whether it's unilateral movement or bilateral movement. There are so many practice variations. So we'll discuss about how the unilateral or bilateral movements are, helpful in stroke rehabilitation. So as he mentioned, so it can be combined with, motor imageries or conventional therapies like, NDT or, motor relearning therapies or, any exercise rehabilitation. So you can combine this as an adjunct. So the patient selections, you can actually, most of the studies have been done in subacute and chronic stroke patient, as well as, the patient with the complex regional pain syndrome following stroke. We have done a study on acute stroke patients as well. So you can include any patient with the flaccidity or better motor ability. There are no clear evidence available, but most of the studies included the wrist movement as a guidance. They should be able to have at least active wrist extension. It is one of the predictor of predicting upper extremity hand function. So they chose as one of the factors. So cognition, you don't want to have any confused people or who is, unable to follow the directions or, who cannot actually follow either with a therapist command or by themselves. And also this mirror therapy needs attention. So you need a patient with the attention, we don't want the patient to be, attention deficit. And they should be able to concentrate at least 10 minutes, because in some type of acute stroke patient, they were very hyperactive. They are, they may have some cognitive issues. So you have to choose the patient with no attention deficit. So other thing, actually, they should be able to see the clear image. For example, if they have, blindness, for example, occipital lobe, so you don't want to include, those type of patient who cannot see the image. And if they have any double vision, it's fine, because you can cover the other eye. So in that way, they should be able to see the clear image. And they should have a trunk control. You don't want the patient to, fall out, while doing mirror therapy. And unaffected extremities, because most of the time the mirror therapy involve using the unaffected hands movement, right? So that movement we are going to see in the mirror to create vivid sensation. So technically mirror therapy is about tricking the brain or fooling the brain. So as the author mentioned that, the patient knows, this is not the affected hand, but we are going to create a vivid sensation in such a way so that it creates a different neural circuit. And also when you do, the arm movement, we don't want any patient to have any cardiorespiratory issues, because sometimes they may have, with the open heart surgery, any of the surgeries, they may have, arm movement limitations. So we don't want them to have, any issues. So mild neglect, can be included, but if it is severe neglect, if they have a strong preferential gaze towards the unaffected side, so then it's very, very difficult to bring their head to the midline. So we don't want any patient to have severe neglect. But again, as a trial, you can see, and it may be a little bit challenging for you. There is no right or wrong, but most of the studies, they included only mild neglect patients. But it will be a lot of work to bring their attention to the center line. You can use this mirror as a center point to focus so that they can do some exercises. So I included actually a couple patients. So I was about to have one acute stroke patient today, but he's having a conflicting schedule. He's going for some diagnostic testing, so he's unavailable today. Otherwise, he's one of the best patients to practice. I taught him this morning about mirror therapy and how to use it. He has been practicing since yesterday. So we will actually go through a couple case study scenarios to see how you will feel about including this patient or excluding this patient for mirror therapy. I will read this case. A 79-year-old patient admitted with a large ischemic pneumora. pneumora affecting the right frontoparietal lobe. The patient has a history of right TIA about 10 years ago and peripheral arterial disease. He presents with the left upper extremity weakness, 3 out of 5, MMT score throughout, sparing left leg function. He was alert and oriented with intact vision, sensation, and perception. He was independent with bed mobility, transport, and ambulation using a two-wheel walker. A walker was given to improve his proprioception. His alpha film score was 104 by over 116. So what do you think about his criteria? Will he meet the criteria for mirror therapy, or will you exclude? Do anyone want to volunteer?
People can type in the chat if they would like, or unmute. Sherry says he meets the criteria.
Okay, wonderful. Yes. So this patient actually meets the criteria. The only thing is in this case is he has pure motor weakness. His cognition, sensation, everything was good. So he will be a fantastic candidate. The other patient is actually 56 years old female admitted with the dense left MCA stroke. She has flaccid paralysis on right upper and lower extremity with aphasia. She is unable to follow direction, scored 20 out of 116 on alpha film score. Will she be a good candidate for mirror therapy? Anybody want to actually discuss about this? What do you guys think? Do you think actually she will be a good candidate or not a good candidate?
Type in the chat again. Not able to follow directions, so not a good candidate.
Yeah, good. So also actually in this case, we will so with regards to aphasia, there are two types of aphasias, as we know, receptive and expressive aphasias. So patient with I have given actually mirror therapy to expressive aphasia people who is able to understand the concept but unable to express their need. But with the receptive aphasia, it's quite difficult. So they, when you teach something, they actually do something else. So I would include, even with aphasia, if it is only expressive component, you can include mirror therapy to them. So the less appropriate patients are with the poor cognition and are not able to follow commands or directions, or who have attention deficit and who has very poor sitting tolerance and severe neglect. So the patient can't see the mirror at all. So who has severe neglect. So these are actually less appropriate patients. So position, actually how you will do mirror therapy, whether you can do in sitting posture or sitting or standing posture. So for upper extremities, the sitting posture is more appropriate. For lower extremity, either you can do a long sitting posture or standing posture. So maybe in future, so we can actually do for lower extremities once we have a proper mirror for the lower leg. So mirror matters. So as I discussed before, this is the minimum standard size for upper extremity rehabilitation. So they did actually include 32 trials. So the larger the mirror have the better effect according to this author. So they did a systematic review in 2019 and included a 50 by 40 centimeter mirror. So that's what actually Sue utilized in her mirror box. So the mirror should cover the entire affected limb. We don't want that affected limb to be out of box, or we don't want the unaffected limb, not fully covered in that mirror. So when you're handling the mirror, make sure you handle with care, because we don't want to actually, we are here to help the patient. We don't want to injure any patients. So the mirror should provide a clear image of unaffected extremity. So when I was actually searching online, so sometimes they use a kind of sheet, it's like a mirror sheet. It's not producing a clear image. So it's up to you if you are making one for your patient. Just make sure you make you buy a good mirror So what type of mirror we bought, Sue? It's not like a old fashioned mirror.
It's not glass.
It's not fiberglass, something like that. The
Yeah,
fiber
or acrylic or
plexiglass. You're
something.
right. So
Yes.
Jim knows it's a
It's not-
plexiglass.
It's really not breakable because I mailed a bunch of them out and they all arrived safely.
Yeah, wonderful. And when you set up mirror, it should be at the eye level so that they can see the clear, their limb clearly.
Ben, when you say the whole extremity, do you mean right from shoulder to fingertips? Is that what you mean by the whole extremity?
Yes,
Okay, thank you.
they should be able to, hide it. If they are going to hide it, so we will place the mirror in such a way they won't see the shoulder or anything, the affected extremity. But when we place the mirror, we just want to make sure, they are able to see their whole upper limb.
Thank
The
you.
more you have, visibility, then it's better. So environment also very, very important. We don't want any patient to be in a busy environment. The environment has to be very, very quiet so that they can actually focus. So some patient actually asked me, can I use my cell phone? It's not really, recommended. You cannot really get a vivid sensation if you play with your phone or watch TV, or if you talk to your, family or whoever it is while doing mirror therapy. It's not going to be effective. You will be making movement without creating vivid sensation. There is no point of doing it. In that case, it's important not to waste your time on mirror therapy. Better focus on conventional rehabilitation. In that way, they can actually do exercise on the affected extremity and talk to the family members. Every patient is different. They may have different needs. For example, if they have any family visiting out of town, they want to actually spend some time with them, right? So if they need your help or assistance, so we have to actually prioritize their need, and based on that, you may have to adjust the schedule. And also jewelry should be removed. So the concept is even tattoo or jewelry, it has to be covered or remove. Tattoos, we cannot actually remove it. It has to be covered. That's what actually they studied. In my understanding, we don't want to, we don't want the brain to, perceive wrong information. So mirror therapy actually technique. So most of the studies, how they did the treatment range from 10 to 30 minutes with the different anatomical movements. So there is no right or wrong. So you can actually, because they are going to do movement on the unaffected side, so you can create any movement. So you can ask them to do, finger flexion or extension or up position, wrist flexion, wrist extension, any anatomical movement possible, they can do it. So there is no, limitation on the number of exercise, but mostly they did, that the intensity was, they can do 3 to 5 days a week for 4 to 6 weeks. Most of the studies they have done up to 30 minutes. So Jim has an experience. In my protocol, I told him to do 30 minutes, up to 30 minutes. So when he did it, he was exhausted. So his suggestion would be, he can do those mirror therapy 15 minutes, 2 times a day. So unilateral or bilateral movement. So again, actually, most of the studies they have done with the unilateral and bilateral movement. I personally like unilateral movement. I also actually reviewed some of the articles. They are in favor of unilateral movement. That means you don't need to actually intervene affected extremity while doing mirror therapy. Just actually do our normal movements with the normal hand using the mirror, because that improves the patient experience and create more vivid sensation. When you ask the patient to do movement on the affected extremity, for example, if I have only 2 plus or 3 out of 5, so I won't be able to move my affected hand. So how I will do? So I will do this while my full attention will be on the affected extremity. So the chances of getting the vivid sensation is very, very, very low when you actually involve the affected extremity in the treatment protocol, but the vivid sensation will be very, very high with more attentive movement using the unaffected extremity alone. So, for example, in a systematic review, they did a subgroup analysis, including actually both unilateral and bilateral movements. So they revealed that unilateral movement, improves motor performance well than the bilateral execution. So some studies they proved that both are effective, but overall, the unilateral movement, using the unaffected extremity created more, value than using the affected extremity. So other thing also, manipulation objects, you might watched in YouTube video that, sometimes they watch, mirror and, they play with the objects. So again, actually, there is an author, so 30 trial included, using manipulation objects. So they found that, there is no benefit of using including objects during mirror therapy. So my, that's how I feel like it. I like with those authors because I personally experienced with a few patients, how do they feel it? So overall, the intention is we want the patient to experience vivid sensation, but when you are doing, bilateral movement or when you're asking the patient to manipulate the object, their attention is distracted towards the affected extremity than, unaffected extremity. So I personally don't like it. Again, it's up to you. So I'm not saying, this is right or wrong because, there are some bias also in these literatures because most of the studies, they included smaller sample size. But overall, the study systematic review concluded that, we don't need to actually include a manipulation object. We don't need to include affected extremity in this mirror therapy. That's how I've been following, but it's up to your decision to use. So the next, thing is when you're developing a home exercise program, for example, in acute care, I do, provide mirror to my patients. I teach them actually just a few minutes, not even 5 minutes. They just want to know how to set up. And, I ask them to play with any type of movement they want. They do it. And but you need to, select the patient appropriate for this mirror therapy. So you can use the exercise based on simple anatomical movement. As I mentioned, it's not a difficult, technique like, NDT, you have to use your hands there or here. It's not like that, but it has a similar effects. And also, if you see this, evaluation of mirror therapy, I can actually circulate this, this template to you. So it gives, some compliance. If you give this sheet to the patients, if you ask them, okay, did you do it? They mark it down. It's a little bit extra work for them. They may have to spend another 30 seconds or to 1 minute to record this, but we can actually see if they are compliant with the mirror therapy or not. So it has just 4 components. When did you practice? We need to, just AM or PM, or they can record the timings. And how long did they practice? This is very important because when they do, whether they did initially for 10 minutes or 30 minutes like that, you can keep track of their progression as well. For some people, it may be 10 minutes. With 10 minutes, they will be exhausted. Although they are doing movement on the unaffected extremity, because they pay full attention, their brain is fatiguing very easily. So their tolerance may improve over a period of time. And also you can see, you can compare if the patient does 15 minutes, whether they show better results, or, 30 minutes, they show better results. So which exercise did you practice, number of repetition, for example, whether they include a, shoulder, wrist, or elbow, like that. So the next one, how was the vivid, how vivid was the mirror illusion? That's more important. So when a patient records 0, 0, 0, 0, out of 10, that means they are not paying full attention to the mirror. So some of my patients actually who said 8 or 9 out of 10, they didn't have a strong, vivid sensation. Some people, they said 4, but I never seen anyone reporting 0 in my experience here, if they do very well. So if you see them, they're recording vivid sensation, that means they don't understand what vivid sensation is. or they might be doing it wrong. So you may want to track, few days how their experience is, so you can educate them again to use mirror therapy properly. So these are my patient experience. So one of my patients said easy to do, and it improved my hand function. I felt movement on my affected hand, although I didn't, do movement with that hand. So most of my patient, actually, it helped me to sleep better. So it is not our physiotherapy objective or occupational therapy objective to, have a, sleep in our protocol. But when you do this movement with the mirror, with the vision, the brain fatigue very easily than doing a physical exercise. Even with the 10 minutes exercise with the mirror, people slept better. They are not, some of them even didn't take melatonin or anything on that night. So it does help them with, sleeping. So when they sleep better, they, do exercise on very next day better. It also improves their quality of life. And some people, they said it made me very tired after mirror therapy. Of course, when you pay full attention, it fatigue your brain very easily. And this is a very interesting patient I saw with one patient. For a moment, I completely forgot which side is the affected side. So this is actually, although this patient had a very strong vivid sensation, but this is alarming for us, right? Because when they forget which is affected side, there is a fall risk. So the patient may fall if we don't adapt a good posture. It's a transient effect. It's not a permanent effect on their brain. It's a transient effect. So that's the reason you need to make sure, your patient is in a proper seating posture, when you do this mirror therapy. So now, I think we covered most of the theoretical component. So we have Jim, here to share his experience, how he did mirror therapy and what he perceived from mirror therapy. Then he is going to show us how he practiced mirror therapy. Okay. So
Great. Can you stop sharing, Ben?
Sorry?
Stop sharing your PowerPoint. We'll have a bigger picture of Jim doing his thing. Thank you.
Okay, wonderful. So Jim, do you mind actually, talking to them about, how you felt about mirror therapy?
Is there a higher volume?
Okay, 1 second. Let me increase the volume.
I can hear you pretty well. People at their sites can increase their volume if they need.
Oh, it's 100%, Jim.
Okay, you have to speak a little louder because I've lost some hearing as part of my stroke. So we're just getting new hearing aids now. But one of the things when I started into the mirror therapy, I quickly learned that you had to do it. In my case, I went to the basement recreation room and turned the television off, turned the computer off, even though it was on standby, it would light up once in a while. And I even went so far as to shut the blinds. So there was no distraction. Shut the cell phone off so it didn't beep. So my world was the mirror box and the table that I was sitting at. If there was people vacuuming, my wife vacuuming, for example, she couldn't do that. I had to stop her. I had to be in my own little world and I used a kitchen timer. So I set it at 30 minutes. So I didn't look at my watch. I didn't look at the phone if it was on, just the timer sitting on the desk. And when it hit the 30 minutes, then I was done. I would peek at it to see where the knob was, because 30 minutes of mirror therapy is extremely tiring. In the end, I would do it for 15 minutes and then stop, take a walk upstairs, get a drink of water, come back down, and then I'd do my last 15 minutes. That 5 minutes seemed to rejuvenate me as I went along. One of the things that I committed, I think, to doing it for 4 weeks, I believe it was 4 weeks, was that you can easily go off the rails. Oh, I'm tired, or I have to do something. You have to, I kept it, after a week, I got a diary, which was just a calendar. And I knew every day I had to do my exercise. And if I skipped a day, then I couldn't write it on the calendar. And I can't make up a story, to be honest, with Vin and Curvy as a helper and myself. I was guilty of getting distracted. And then I said, well, that's okay. I'll do it 2 times tomorrow. Well, tomorrow never came. So it's adamant that you must stay to your schedule, and preferably, if you could set it, say for after breakfast or after lunch or at 11 o'clock before lunch, be consistent, because once you go off the rail, it's hard to get back on. So I set a time, and in my case, the best time was 5 o'clock before supper. The house was quiet. My wife was watching her TV show. So I was by myself. In the case of the box, I originally started by my left side was the problem. My left hand was the big problem. I couldn't do anything with it. I couldn't do buttons. I couldn't pull my zipper up. I couldn't hardly even scratch my nose. So I left the hand inside the box and just did my exercises with my good right hand. And I did the thumb to the fingers, all 4 fingers. And then I did starbursts. I did Star Trek salutes. I did Fox, when you used to do shadows in the tent at night with a flashlight. I made little birds with my fingers. You just keep thinking of ways to move. I did wrist rotations also, and I did wrist up and down, break my wrist, straight up, straight down. It doesn't matter as long as your hand is moving. Later, after a couple of weeks, I started to move my hand inside the box to imitate what my good hand was doing outside the box. And I'm not just quite sure if that was an advantage or not, but today, all my fingers work, and I can do up my own shirt, my own buttons. I pull up my zipper of my pants. I can do things. I can pick up my fork to cut my meat or my food or whatever with my left hand. My left hand has not come back to the exact strength of my right hand, but I'm on 2 canes now because I did have open heart surgery after the stroke. So we found out what caused the stroke. But the mirror box, it was doubtful in my mind, what kind of a thing is this? But in speaking to my sister, she knew all about mirror therapy for amputees from her career in nursing many years ago. So it works. It's crazy. It's unbelievable, but it works. So I'm glad I did it.
Thank you so much, Jim. So also, actually, I just want to share my experience with a couple of my patients. So we did actually a research on acute stroke patients, but as when one of the patient came from Campus Casing, who is not part of our trial. So he wanted to actually, Dr. Singh, who is a stroke neurologist, introduced mirror therapy to him. Although he didn't meet our criteria, we just actually want to see how he feels. So I educated him and his wife how to do it. And after 4 weeks, they did actually meet with the Dr. Singh. They did notice major difference on his hand function. They didn't even want to actually, hand over the mirror to me. So I gave 1 mirror to them because they travel 4 hours to learn about this simple technique. So this type of mirror is, if it is going to actually make a major change in different, people life. So I had no issues giving one mirror to them. So that I made it myself. I gave it to them because I made two mirrors for myself from my out of pocket. But it was really helpful for a patient. And also, I did use mirror therapy for one of the amputee patient who experienced phantom pain. It does really help. When I was actually doing community work, the patient, I was doing exercise, all of a sudden he was, scratching below the knee where there was no limb. So then I discussed about him about the, mirror therapy did help him, significantly. So this is one of the inexpensive and easy technique to be administered by, patient themselves. All you need to do is you just need to spare a few minutes time to educate them about the benefits. So it's up to the patient to, take that therapy, as a treatment or not. Thank you so much for everyone time. So now we are going to actually set up the mirror therapy so you can, I'm going to actually move the laptop in different directions so that we can have a full coverage. Please give me a few minutes. So we'll set up the things.
Thank you. Maybe
Thank you.
people at their sites could set up their mirrors and open their cameras so that we can do
wonderful.
some back and forth visualization of what people are doing.
Wonderful. I'm going to mute.
Yep.
Okay, thank you.
If you have any questions as we go, feel free to put them in the chat. I'll read them out to Ven, or if you'd like to unmute, just go ahead and unmute or raise your hand and you'll have the opportunity to ask your questions. I have a couple waiting in the wings here to ask them. Also a reminder to make sure that your name is typed in the chat or in the participant list so I can ensure that you get your certificate. I'm also going to just put in the chat the evaluation link. If you could take a moment before the end of today and fill out the quick evaluation for us, that would be helpful. Thank you.
So actually we are ready. If everybody is, ready to start, we can actually go over it.
Yes, please. I
Okay,
put the
wonderful.
evaluation link in, but it gave a different title. Just ignore the title. But the evaluation link's correct.
Okay, so how we did, so if you see this is actually a moving table. So we set the mirror in here. So if you see here, his affected hand, so his hand is actually, improved a lot, but this is
Mhm.
affected hand is fully hiding inside the box.
Mhm.
And we put this here, if it is just to make sure the mirror is not moving when they actually do exercise, because we don't want the mirror to fall out of the table or anything like that, just to make sure it is fully secured before you intervene. The setup is the most important factor. So now we see here, Jimmy is able to see the mirror. So I would actually theoretically, practically, I will ask him, one second, to remove his shirt up to here. Okay.
So the mirrors that I made for people do slide open a little bit when they're set up. So make sure you put them against a wall or put a heavy book. So like Ven says, that they don't move.
Are you okay? Okay. Can everyone see the mirror, or do you want me to actually move the laptop?
Move the laptop maybe a touch to the right.
Here?
Yeah. Yeah.
Uh,
Oh,
Oh,
it's a little
sorry.
too much. Yeah,
Actually,
I
it's
think
actually
that's good, eh, people?
too bright, actually. The room is too bright with tube lights. So if you see, I'm not able to see
Yes, we
myself.
see it fine. It's good.
Okay, wonderful. So he is making, he's hiding the affected limb. So we have to move this. Jim, do you mind actually covering your limb up to here? Yeah, just move there. 1 second. We have to actually position in a diagonal way. Yeah, good. See here? Now actually I fully covering his unaffected extremity. So now he is making movement with his unaffected extremity. He can make any anatomical movement. He can make actually finger flexion, finger extension, wrist flexion, wrist extension, as long as he is able to see a full movement.
So then can I verify when they're
Yeah.
doing this, that they're always looking at the limb in the mirror?
Yes, they have to. So
They
he is
have to be
looking at the
looking
mirror. Yes.
at the mirror and
Yeah,
not at the
otherwise,
limb.
yes. So they have to look at the mirror and see the anatomical movement. If they don't look at the mirror, it's not going to be effective at all.
Right.
It's a usage of, it's a wastage of time if a patient doesn't,
Right.
see the mirror fully. Our concept is to create a vivid sensation.
Right.
It's
My other
important.
question is, do you give them kind of a list of ideas of things, movements they can do? And would you have that available for people here? Because I know Jim was talking about things that he does, and I feel like he probably was told a few things, and then some of the things he's made up on his own. So is there kind of a list or an idea list somewhere that people could access?
Yeah, so you can actually create a simple exercise movement where, anatomical movement, simple wrist flexion, extension, any movement you can actually create. But again, the concept is if you tell them, do wrist flexion 10 times, they may be tired, right? So you have to give them time so that they can alternate movements from, finger flexion or finger extension to it. So every patient is different. Some people, they get bored, some people they do it. So, but according to the patient learning experience, we have to adjust the exercise so that they can have vivid sensation.
And if it's their whole arm that's not moving, do you concentrate more on arm movements rather than finger movements, for example?
The whole movement, yeah.
Yeah, you would start
Whole,
there.
yeah.
Okay.
So if you
Anybody
see
have any
actually,
questions?
Jim is able to look at the mirror. So it is at his eye level. He's able to see the whole, unaffected extremity, the right arm into the mirror. If you see in the mirror, so he sees the right arm as left arm. The concept is we are going to trick the brain. So there is no limitation with the number of exercise. You can progress from 10 minutes to 30 minutes. The more they do, it's better for them.
Okay.
It's important to look into the mirror. Don't get caught looking at your hand over
Yeah.
here. But so for my use, I like to get around in front of it. And now I'm looking into the mirror. Just
Right.
there's my left hand right there.
Right.
Don't look at this one.
Yeah, you're right, Jim.
And I gotta look, even though I'm here, see if I'm here, if I'm on the end of it, looking here, I don't see my hand so well in the
Right.
mirror. I see my right hand which is the good one. But if I come around to the corner, now I'm looking right into the mirror. In this case, I'm looking at that sign behind us. So it's to get in there, to look at the image of your left hand. And that it's working itself.
That's excellent. Someone had just asked the question, they looking at the unaffected side that, and are they looking like in the mirror, or are they trying to do the exercise and looking at the affected side? So
Yeah.
really looking at the mirror is the key, Jim. That's what you're
It's a
saying.
key, yes.
Thank you. There's another question, Ben. As the good extremity is in elbow bent position, do you position the affected extremity in the same position?
It's not necessarily, but you can try it for sure.
Oh, okay.
Yeah, so all we need to do is we need to hide it, and you can either keep the elbow bend or straight. It doesn't matter, but you have to make sure the affected extremity, whatever is hiding in there, is comfortable, because if they have any weakness, so if they hold the extremity in elbow flexion for 5 minutes, they may end up having soreness. So you just make sure the patient doesn't experience any negative experience while doing mirror therapy. So the patient should not focus on the affected extremity with the pain or anything else.
Excellent. There's another question. Do you have any suggestions for ignoring the sensations felt by the hand in the box? For example, feeling the table on the fingertips.
That's actually amazing effect. So that means the patient has strong, vivid sensation. So when they have a strong, vivid sensation, definitely they will feel like the affected hand is moving.
Okay. I have a question from Harish wants to know, if you look from front, how will the brain perceive it as the opposite limb?
So that's the reason if you actually do exercise with a mirror on the side, so after a few moments with the full attention, your brain will automatically pick that as the affected hand, because that's opposite image.
Okay. Excellent.
Yeah, again, actually, as the author said, that the patient knows that his left arm is paralyzed. He's not full, but we are tricking the brain by creating a visual image, which
Just to
help to create a neural circuit.
Right. Okay. Just wanted to clarify the question about ignoring sensations felt by the hand in the box. Meant, how do you ignore the sensations felt by the hand in the box that doesn't match what they should be feeling? So feeling the table instead of finger opposition, which is shown in the mirror.
So if they feel any unwanted experience, you can give them break and ask them to retry again.
Okay. So if Jim has his affected arm in the back and his hand is resting on the movable table and his
Right.
hand can feel that, but in the mirror, he's actually pressing his fingers together, he should be having that feeling, right? So that's kind of a juxtaposition. What would you do about that?
Right. So for example, in this case, when a mirror image is created, if they if they make any anatomical movement, they can experience any type of sensation on the affected extremity. That is something normal to have with a strong, vivid sensation.
Okay. Any other questions? Does anyone want to demonstrate what they're doing with their mirror and get some feedback? And just unmute if you'd like. Sherry's asking Jim if he can speak to what his affected hand is doing at the moment.
So Jim,
Oh,
Jim
it's-
is doing exercise here, so they want to know what your
It's starting to, it automatically starts to twin what this hand is doing.
okay.
And sometimes it hits the back of the mirror, but it's not really,
It's not really.
it's not exactly what doing, but it wants to. It wants to do it. So if I'm doing this here, I'm getting most of them. For sure, I always get my first one, which is my best one.
Yeah.
But after that, it tries to catch up.
Can you show behind the mirror box, Ben? Are you able to show while he's doing the actual mirror? Show both hands a little bit higher.
Okay.
Oh, a little bit higher.
Higher?
Yeah, higher. No, that's lower. To point up towards the ceiling more,
Or ceiling more? Okay.
because we can't see his hands.
Okay. Oh, okay. Jim.
Yeah.
Okay.
There.
One second.
Yeah,
Okay.
yeah, that's better. Okay, now if you
Better?
want, Jim, show us what you're doing with your hand and. So
So
you're,
Jim is doing a bimanual task now.
okay,
So we don't need to do a by manual task when you're doing actually mirror therapy. You can ask, your patient to rest their left hand comfortably on the hand, on the table, so that actually, they focus more on the mirror.
Right.
Any other questions?
Excellent. Thanks for showing, they appreciate it. I wondered if Temiskaming wanted to show something or unmute. I saw you guys, ladies moving around there. Are you good?
Yeah, we're good. We're good. We're enjoying the mirror box that you gave us. And we had the same question, actually. We wanted to see what Jim's hand was doing.
So again, actually, Jim is one of my patients. So I gave it to almost 30, 40 people now. So everyone have different experience. So some of them, even with the mental imagery, actually, they did feel the movement. So I'm sure it will be like a magic when you do mirror therapy with your patients. If you do it for a year or so, you will have a lot of learning experience and you can actually share to your peers for sure.
Mhm. Ben, can you tell us a little bit about the lower extremity and what that mirror setup might look like for people that
So
want to do it with
for lower extremity, we need a long mirror because the leg length is really long, but this mirror only covers the upper extremity. So
Right.
some studies they have done when in a long sitting posture in a hospital bed or in a bed, so that it's like a Frankel exercise. How you do Frankel exercise? So your patient have to see the extremity, lower extremity, when they do a coordination exercise when they are lying in bed, right? So similar way, some people they did it, some of them they did in a standing posture, covering the mirror on the affected extremity, but you have to make sure whether they can stand with support or without support. So the fall risk is very high if you're doing mirror therapy with standing posture. If they are affected leg is weaker because they cannot hold themselves for a longer time, right?
So would you use like a full length mirror? Is that the type of mirror you would use?
We will use similar mirror in a lengthy fashion. I can actually share the dimensions, what they have been using it for lower extremity.
Okay, if you could
Yeah.
send that to me. I have a few things I'm going to send to people. I'm going to send out
Sure.
the form that you showed in one of your slides. I also have a page I put together on how to make the mirrors that I sent you. So people can keep the mirrors I sent, but if you wanted to make more, if you had a patient or client that wanted to make one, I'll send that. And then if you could give me the dimensions for the leg mirror, then I could also send that out as well.
Sounds good. Thank you.
Almost any glass shop that sells windows and doors and fixes things, they sell this plexiglass mirror. And we use it, we used to have a business, we supplied plexiglass mirrors into homes for handicapped people or community living, where sometimes they were prone to break the mirrors. With a plexiglass mirror, nothing happens. You just bounce off it. And they'll cut to fit whatever size you want. And they
Excellent.
can even put a little frame if you want, but it's
Mhm.
not necessary.
Mhm.
And
Excellent.
it's inexpensive.
I think these mirrors that I built and sent out cost between $50 and $75 to make, I think. Does anyone else have a comment or a question? Alan wants to ask, what is your experience and what are the outcomes on patients with CRPS? And I don't know what that is. Can you tell me what that is?
Oh, it's a complex regional pain syndrome. I
Right.
did actually encounter any patient with a complex regional pain syndrome in this last 2 years. So I have no experience, practically applying mirror therapy to those population.
But you are able to do it with that population? Yeah. Okay. Any other questions or comments? Ben, is there anything you wanted to add, or Jim, anything you wanted to add?
Jim, do you want to add anything? Are you good? Okay, wonderful. We are good from our end.
Okay, so I did put the evaluation in the chat. I'll try and put it in again.
Okay.
No, that's not it.
Thank you so much, Sue, for organizing this webinar. I really enjoyed sharing my experience with all our peers. If you have any questions in future regarding mirror therapy, please feel free to reach out to Sue. I can answer your questions. It's a very pleasure talking to everyone. Thank you very much
Yeah.
and have a good evening.
Yeah, thanks very much, Ben and Jim. We appreciate both of you taking the time with us today. And I'll be sending out an email to people shortly with some of the information that I promised. And if you don't receive a certificate from me in the next week, just fire off an email because I might have missed your name. So thanks so much, and I hope everybody has a great day.
Thank you so much, Jim, for coming all the way.
Not a problem.
Thank you so much.
Appreciate it, Jim.
Bye now.
Bye now.